Hello and welcome to the ARC Talks webinar series. Today's talk is on the contemporary management of AL amyloidosis, treatments and clinical trials. I'm delighted to introduce Dr. Heather Landau, a hematologist at Memorial Sloan Kettering in New York and a leading authority in the treatment and management of amyloidosis. In this presentation today, Dr. Landau will cover the current treatment options for all types of patients with AL amyloidosis. Thank you. Dr. Landau.
Hi, my name is Heather Landau from Memorial Sloan Kettering Cancer Center, and thank you so much for having me today. Here are my disclosures. Today I'm going to outline facts about light chain amyloidosis. We're going to talk about the standard of care for therapy, second-line therapy, side effects and symptom management, as well as future directions. So what is amyloid anyway? Amyloidosis is a general term given to a relatively rare group of disorders, the so-called protein misfolding disorders, in which an abnormal protein misfolds into a unique structure, the amyloid fibril. That amyloid fibrils then can deposit in organs and tissues of the body and disrupt normal structure and function. Amyloid means starch-like, which is a substance that's not readily broken down and therefore accumulates. Many different proteins can form amyloid. AL amyloid, or light chain amyloid, is the most commonly diagnosed form of amyloidosis, and it results from a plasma cell disorder. Plasma cells are a particular type of white blood cell. They're part of the body's immune system, and they produce antibodies or immunoglobulins, which are important for fighting infection. When plasma cells go awry, a single population of plasma cells grow and produce excess amount of antibodies or immunoglobulins, which are made up of heavy chains, this blue entity, or light chains, the red entity, and it's these proteins, the light chains, that misfold into amyloid fibrils. We have our antibodies make both kappa and lambda light chains, and so the deposits in amyloid are either kappa or lambda typic. Here you can see the typical organs that are involved when amyloid affects the soft tissue. Bruising, especially around the eyes or an enlarged tongue, which is suggestive of amyloid, but only occurs in about 20% of patients. Amyloid deposits in the heart, making the heart thick and the muscle stiff. Typically, the heart with this small cavity is unable to fill, and the blood gets backed up. Patients who have cardiac involvement can present feeling fatigued or short of breath. They can have ankle swelling or be lightheaded when they're standing. Amyloid in the kidney leads to loss of protein in the urine because the kidney's normal function is to filter the blood and get rid of waste. When it works properly, waste is excreted and good proteins remain in the blood, but when the amyloid damages the filter, the glomerulus, it allows normal proteins to leak out. The most commonly lost protein is called albumin, and this leads to low levels of albumin in the blood. Amyloid in the GI tract can prevent food or nutrients from passing through properly. It impairs absorption, leads to diarrhea or constipation, sometimes bleeding and weight loss. When amyloid deposits in the liver can be enlarged and sometimes fill the abdomen, causing abdominal bloating. Numbness or pain in the hands and feet results from amyloid deposits in the peripheral nervous system. And when the autonomic nervous system is affected, patients often have low blood pressure when they go from sitting to standing, and even have fainting episodes. The most frequent symptoms are seen here. You can see they're really nonspecific and mimic symptoms related to more common conditions, and this leads to late diagnosis. On average, patients see 4 doctors before being diagnosed correctly, and in a survey of 443 patients or their caregivers, 220 cardiologists actually missed the diagnosis. In an effort to understand patient risk, a staging system, which is an assessment of disease severity, has been devised because the cardiac involvement is the main determinant of survival. The cardiac biomarkers, which indirectly measure organ damage, troponin, NT-proBNP, and a related biomarker, BNP, are used, and patients can be stratified based on the values of these markers. You can see here that we call patient stage 1 if these 2 markers are normal and these patients have the best outcome, whereas if these markers are abnormal and high value, these patients do fairly poorly. Similarly, in order to determine which patients with kidney involvement are at risk of developing end-stage renal disease and requiring dialysis, a kidney staging system was created. This system is based on how much protein the kidneys are losing in the urine, as well as the glomerular filtration rate, which estimates how well the kidneys are working. Patients who have low protein and normal renal function are characterized as stage 1, whereas patients who have both high protein in their urine and a compromised kidney function are characterized as stage 3. And patients with stage 1 have limited risk of progression to requiring dialysis, where patients stage 3 have a high risk of progression to hemodialysis. So here is the good news. The main goal of treatment is to target the diseased plasma cell and improve organ function and prolong survival. So with our therapies directed against the pathologic plasma cell, we can see reduction of the serum free light chains, resulting in a hematologic response. And once we achieve a hematologic response, organs can improve, and in that case, we see the biomarkers reflective of the diseased organs become reduced. And we see that patients who have both a hematologic and an organ response have the best overall survival. Patients who have a hematologic response do quite well indeed, and patients with no hematologic response do poorly. So in order to know if the treatment is working, which effectively should decrease or eliminate the pathologic plasma cells, then we can measure the free light chains in the blood. Again, the free light chains are the pathologic entity produced by the plasma cells in the bone marrow. If we eliminate the free light chains entirely, we call that a complete hematologic response, and patients have prolonged excellent survival. When patients' free light chains are reduced below a certain threshold, we call it a very good partial response, and these patients do quite well. Patients who have less than a very good partial response or no response have worse outcomes. An organ response depends on the depth of hematologic response, and you can see here that patients with complete hematologic response are likely to improve their organ function, and patients with less hematologic response, have less likelihood of having an organ response. MRD is a term that means minimal residual disease, and we're really learning how to use these tests, which measure the evidence of disease by our most sensitive methods. We can see that in a small population of patients that were tested, if you can achieve or eliminate disease by this most sensitive testing, it really results in a high likelihood that the organs will improve. Well, this is a complicated slide. I just wanted to show you that, like we have definitions for staging, we can also use the cardiac biomarkers and kidney parameters to grade responses. Not surprising, patients who have a cardiac response, which is defined by an NT-proBNP decrease by 30% or greater than 300 nanograms per liter, have a better outcomes than if one does not have a cardiac response or has cardiac progression. Similarly, patients who have a renal response defined as a decrease in their proteinuria have less of a risk of requiring hemodialysis. But one must appreciate that organ responses take time, and although we can often control the light chains relatively quickly, organ responses evolve and the organs improve over months to years. So here's an example, and I show a patient who disease was measured by her free lambda light chain. It was in 2008 that she received a stem cell transplant. After the stem cell transplant, you can see her free lambda light chains were still in the abnormal range. She received a consolidation regimen with bortezomib and dexamethasone and quickly normalized her free light chain. And still to this day in 2019, she remains in hematologic remission. At diagnosis, she had a high burden of protein loss in her urine, 21 grams. And again, this is 2008 when she went into hematologic remission, but it wasn't until 2014 till her kidneys improved to the extent that they were only spilling less than 1 gram of protein, and it's not until 2019 where we can no longer detect protein in her urine. Similarly, her serum albumin level, because she was losing a great amount of protein in her urine, was very low. Over time, with the reduction of protein loss, continues to improve, and although, again, she had a hematologic response, her disease was controlled in 2008, it's not until 2012 till her serum albumin normalized. And so this just speaks to it takes a long time for organs to improve, and the supportive care that's required, despite the hematologic response for patients, may be necessary over time. So what is the standard of care for patients in terms of treatment? The one thing that must be known is that there is not one single FDA approved drug for this condition. That's why, as investigators, patient advocates, physicians, we really favor treating patients on clinical trials, which allows us to systemically treat patients and capture the data so that it can be analyzed and presented to the FDA for their consideration for approval. So the first treatment for AL amyloidosis was the combination of oral melphalan and prednisone, and because this was the first regimen that led to hematologic response in about a quarter of patients. Outcomes were not great. Patients lived about a year, especially in patients with cardiac involvement. We now have several regimens that have been tested, although none, again, are approved. And here I show the most commonly utilized upfront therapy, risk-adapted melphalan dosing and autologous stem cell transplant is really offered to our healthiest patients, and I'll show you some data to support that. Cyborg-D, which is a combination of cyclophosphamide, bortezomib, and dexamethasone, is a commonly used regimen in the United States for patients who are not transplant candidates. The combination of bortezomib, melphalan, and dexamethasone has been studied and preferred in Europe. In patients who are high risk of toxicity from treatment, particularly those with advanced heart involvement, are treated with doublets instead of triplets, or low-dose combinations, and often require intensive supportive care and even treatment in hospital settings. So what is an autologous stem cell transplant? It's a way to deliver high-dose chemotherapy. The stem cells, which are healthy blood-forming cells, are first collected and frozen, and that allows us to give high doses of therapy, which can destroy abnormal plasma cells, but also destroys the normal blood cells. So then the bone marrow, after receiving high-dose chemotherapy, the bone marrow can be replenished using the collected and healthy stem cells that were initially harvested. This treatment came about in the mid-90s when it was being used for the more common disorder, multiple myeloma. And in a pilot study of just 5 patients, it was the first time that complete hematologic responses were seen in 3 of 5 patients, and all of the patients who were treated with this had improvement in their organ function and were alive at 12 months. This experience was extended to 25 patients, and ultimately the data, here are data on over 300 patients showing that with this strategy, the average time patients lived was 4.5 years. We can see from these graphs that the patients who had a complete hematologic response, meaning no evidence of their plasma cells or circulating free light chain, had superior outcomes compared to those who had less than a complete response. Similarly, patients who had cardiac involvement, again, the biggest determinant of survival is having cardiac involvement. So those who had cardiac involvement had worse outcomes than patients who did not have their heart involved with amyloid. So although these outcomes were much of an improvement, we also appreciated that treatment-related mortality, or the risk of dying when patients were treated with this modality, was 13% and was closely related to advanced age, cardiac involvement, kidney compromise, and multi-organ involvement. So that led us to develop a strategy of risk-adapted melphalan dosing plus the transplant, and in that setting, the amount of melphalan we gave was dependent on a patient's age and cardiac involvement and if their kidneys were compromised. And after the transplant, we restaged patients, and patients who achieved a complete hematologic response, which was our goal, were observed, and those who had less than a complete hematologic response were offered consolidation. In a series of trials using consolidation after risk-adapted transplant, we initially used thalidomide, and the second trial we used bortezomib, and you can appreciate, although this is a busy slide, that about a third of patients after transplant in both studies achieved a complete hematologic response, with risk-adapted melphalan and transplant. And then with the addition of either thalidomide or bortezomib consolidation, there was both improvement in hematologic and organ responses by the 12-month mark. In terms of second-line therapy, which means what happens if treatment doesn't work or the disease comes back after achieving a hematologic response, we first have to understand the definitions. Refractory disease refers to a treatment that didn't work. So you have a few months, you're given a few months of therapy, and you didn't achieve the response that we desired. Whereas relapse means that the initial treatment worked, but over time the disease can come back. It's also important to understand the difference between relapse and progression. Patients who relapse, again, had achieved a hematologic response to the initial therapy that was given, but then over time there's some evidence of disease in the blood, often at a low level, whereas progression is evidence that the light chains are rising and the organs are potentially at risk for damage. So one of the main questions when we are thinking about when to start a second-line therapy are the organs okay? And there are options, which is the good news. Again, not one FDA-approved therapy, but here are different classes of drugs that have activity in patients with amyloidosis. The proteasome inhibitors, where Velcade or bortezomib is often used in the frontline setting, we now have studies showing activity of Ixazomib or Nanlaro, or an alternative proteasome inhibitor, Carfilzomib, or also known as Kyprolis. The IMIDs, also known as the immune modulating agents, include lenalidomide, pomalidomide, and thalidomide, and I'll show you some data on using those in amyloidosis. The alkylating agents include the standard melphalan, in addition to Bendamustine and cyclophosphamide. And really, the most exciting group of new treatments that are being studied are these immunotherapies, which include monoclonal antibodies. So Ixazomib is an alternative proteasome inhibitor that has been studied. It is an oral drug, and you can see this is a study where patients were treated with single-agent Ixazomib in the relapsed or refractory setting. This is a waterfall plot measuring the change in the free light chain, and going down means there's a reduction, going up means there's an increase, and you can see over 50% of the patients achieved a hematologic response, and that was associated with a similar number of patients who achieved an organ response. This drug is also being studied in a phase 3 setting. It was the first drug going for FDA approval. Unfortunately, we just got word that this phase 3 study did not meet its primary endpoint, but there still does appear to be a benefit of Ixazomib in this disease, and the data are still being analyzed. The drug Carfilzomib or Kyprolis is another proteasome inhibitor given in the intravenous form. In a study that we did of 28 patients who were treated, we found that 63% of patients had a hematologic response, including a number of patients who had deep responses, and the patients who were enrolled really have had good outcomes to date. The majority of patients who were treated on this trial remain alive. However, and although there was no deaths on trial, toxicity is not trivial, and over 70% of patients had adverse events to this drug, including patients who developed cardiac toxicities and pulmonary toxicities. The immune modulating agents also have been studied and have activity in light chain amyloidosis. This table indicates 3 trials. This is of lenalidomide and dexamethasone in the relapse setting. This is of the combination of cyclophosphamide, Revlimid, which is also lenalidomide, and dexamethasone in the upfront setting, and the combination of pomalidomide and dexamethasone in the relapse setting. And you can see that selected patients do well with these agents, with about a quarter to a half of patients living beyond 5 years. Again, these drugs have toxicities. No drugs do not have toxicity, but the particular toxicities we see with these agents include lowering of the blood counts, lowering of the blood pressure, abnormal heart rhythms, and fainting. There's also a phenomenon that even in patients who are achieving hematologic responses, we also see increased values in the cardiac biomarkers, and we're trying to really understand this better. Bendamustine is in the same class of agents as melphalan and Cytoxan, and in a study that we did in previously treated light chain amyloid patients, over half of patients responded. Bendamustine, similar to melphalan and Cytoxan, also caused decrease in the production of blood cells. We are really excited about the novel approaches, namely immunotherapies, that have alternative targets and treat the disease in novel ways. For instance, antibodies can be directed against plasma cell markers on the plasma cell itself. Antibodies can also be directed against the immunoglobulins or the light chains, as well as the amyloid fibrils. This class of drugs targeted a stabilizer of the amyloid fibrils and is no longer being studied in clinical trials, unfortunately, because of its toxicity. So what is Daratumumab? It is a hot topic because of its exceptional activity. It is actually an antibody that targets CD38, which is a marker on plasma cells. Once it binds to the surface of the plasma cell, it induces cell death in a variety of ways. Here I show 3 patients, and the pink line measures their serum-free light chains, which you can see was reduced in all cases by their initial therapy. But if you see that this is the baseline and this would be normal, although the free light chain decreased in all cases, it certainly didn't normalize. And eventually, all 3 patients were treated with the antibody Daratumumab. You can see a prompt response and normalization of their marker of their disease, their serum-free light chain. So in a phase 2 study, 18 patients were treated, and these are results that have been reported, where we are shown here the again, this is a waterfall plot measuring the reduction in serum-free light chains, and you can see it was shown that a hematologic response was seen after 1 dose of Daratumumab in 89% of patients. And often that reduction was quite robust, accounting for a 78% very good partial response rate, again, with just 1 dose of this drug. This led to an ongoing clinical trial where the combination of Cybor-G, which is a standard upfront therapy regimen, was is being compared to Cyborg-D plus Daratumumab in newly diagnosed patients with light chain amyloidosis. This is a global phase 3 trial, which has just completed enrollment of over 370 patients, and it will take some time until we have these data, but the good news is it is expected that in 2020, the Daratumumab may be the first drug approved for this condition. What is Ixazomib? Is a similar antibody to Daratumumab, again, binding to a unique part of CD38 on the plasma cell surface, again, inducing plasma cell death. It works similar to Daratumumab, but binds to a different part of CD38 and is being studied, whereas Daratumumab is being studied in the upfront setting. Ixazomib is being studied in relapsed AL amyloidosis in a cooperative group study, which also has just completed enrollment. So understanding that there are promising agents coming, as well as available agents, again, not one FDA approved, how do we decide on second-line treatment for patients? There's a lot of factors that go into that decision, namely, what have patients received before that they did or didn't respond to? What toxicities did patients endure to prior therapy? What are comorbidities or impairments of the patients that limit use of one drug or the other? And again, access to clinical trials. So the majority of patients we would love to treat on clinical trials because we think that that's the best way to, for patients to have access to treatments, understanding that not everybody is being treated at a center where clinical trials are available. Again, in that case, that we have to really be thoughtful about what treatment, in what order, and in what patient population each of these available agents should be used. Again, some are IV, some are oral. It really depends on, is this patient sick and going to be treated in the hospital? Do they need a rapid response? Is this patient working and has relapsed but has not yet progressed and would prefer to be treated with an oral drug as an outpatient so they can continue going about their business? All of those types of factors play into our decision. And every decision is a joint decision between a patient and the doctor. So the drugs we use do have side effects, and it's essential to manage patients both in the setting of side effects as well as their symptoms from their underlying disease. It's really necessary for patients to seek care from a doctor who's experienced in caring for patients with light chain amyloid because the pathophysiology is really quite unique. So here is a list of side effects associated with the most commonly used treatments. While these all look frightening, in almost all cases and circumstances, these side effects can be ameliorated. This, again, is a busy slide, but indicates that there are supportive measures to help manage symptoms of the disease as well as side effects associated with treatments. For instance, fatigue and deconditioning is really prevalent in no matter what treatment option one is going through, and just by virtue of having the disease, especially when patients are exposed to steroids, which is a fundamental part of almost all of our regimens. Insomnia can ensue, so sleep aids are often helpful because of both the treatment and the disease. There's quite a bit of deconditioning, and really proactively using exercise and physical therapy to preserve strength and conditioning is really, preserve and maintain strength is really quite important. Many treatments have GI toxicity, constipation, diarrhea, anorexia, or nausea, and there's lots of remedies that are available over the counter or by prescription that can be quite effective for GI side effects or GI symptoms. Hypotension, orthostasis, and fainting is commonly seen, again, both with the disease and as a result of our treatments. And we often use medications such as Minidrin, Florinef, Saltabs, and Droxidopa to manage low blood pressure. In addition, we use manual compression with head stockings and abdominal binders to help keep blood pressure up. Edema or fluid that leaks into the tissues is common in patients with heart failure or patients who lose protein in their urine, as well as from fluid retention from our therapies. This requires diuretics, sometimes lymphedema therapy, which are therapists that can actually manually massage the tissues to reduce the amount of swelling, in addition to head stockings, abdominal binders. And I really can't stress enough how, although these head stockings can be uncomfortable, the value in patients with low blood pressure and lower extremity edema cannot be underestimated. Similarly, I call lymphedema therapists our angels because they really make a difference for our patients who really require manual compression to manage the volume. Neuropathy can again be caused by disease or treatment related. Sometimes it's a nuisance when it manifests as numbness, but it could really be painful and debilitating. And there are medicines to help with this. Some patients often find it hard to take a medicine to combat a side effect of another medicine, but really sometimes even we use narcotics to help with the pain associated with neuropathy. And although patients aren't used to taking pain medicines, I call it a pain vitamin. Steroid toxicity can result in insomnia, mood swings, fluid retention, immunosuppression, and by and large, we try to minimize steroids as much as possible. Again, they're effective in almost all of our regimens, but come at a price. Myelosuppression or lowering of the blood counts can be associated with risk of infection and are commonly associated with the alkylating agents as well as the immune modulating agents, and we use growth factors such as Neupogen and antimicrobial prophylaxis as needed to help with this effect. Infusion-related reactions have been seen with the antibody therapies. Infusion-related reactions are really a hypersensitivity that we see as the antibody is being delivered, characterized by fever, rash, hives, can be shortness of breath, even nausea, lowering of the blood pressure, and can be severe at times. However, with adequate pre-medications, we are including montelukast, steroids, antihistamines. We are pretty good at minimizing the risk of any severe infusion-related reactions. Cardiac arrhythmias are seen in patients with both Carfilzomib and the immune modulating agents, and often, as well as results from cardiac involvement with the disease. We often use the antiarrhythmics such as beta blockers and amiodarone, or even maneuvers such as cardioversion or ablation in order to manage more severe cardiac arrhythmias. So the future is bright and promising. There are 61 ongoing clinical trials, 11 are recruiting, and here are selected trials, some of which we spoke about. Upfront trials that are exciting is CyBorD plus minus Daratumumab, which we expect will be the first drug approved in light chain amyloidosis, hopefully in 2020. We are enrolling in an upfront trial along with colleagues in our area of Ixazomib, Cytoxan, and dexamethasone in all oral regimen for patients with in the upfront setting for light chain amyloidosis. At MD Anderson, there is a study using Daratumumab, Ixazomib, and dexamethasone. There is multiple multi-center studies for relapsed patients, including one that is studying lenalidomide, dexamethasone, Ixazomib, which is a novel antibody against a different target, not CD38, with or without Cytoxan, and the Ixazomib, the single-agent anti-CD38 antibody trial that's being done through the cooperative group. There's also stem cell transplant trials that show promise, and Evomela is a novel formulation of the commonly used drug melphalan that we use for as high-dose therapy before stem cell transplant. And because it is a more stable formulation of the melphalan, we can use pharmacokinetic directed studies in order to tailor the dose to the patient in which it's being delivered. Very exciting are these planned trials with novel agents, namely venetoclax, which seems to be very effective for plasma cells with a certain chromosomal aberration, which is seen in almost 50% of our patients. And KAL-101 is a novel antibody that's directed against amyloid light chains and amyloid deposits. And both these drugs will be studied in clinical trials in the near future. Ixazomib, again, as I said, is being studied in the upfront setting at our center and others. We are also studying Ixazomib as a maintenance study in patients who are at higher risk of relapse, namely those who have greater than 10% plasma cells when they're initially diagnosed. About 40% of patients at diagnosis have this characteristic and would be eligible to participate after achieving a response to their induction therapy to using Ixazomib in the maintenance setting, meaning a prolonged therapy in order to prevent relapse. How can we improve amyloidosis care further? I think one of the most important issues is that we must facilitate earlier diagnosis. We can also improve adjunctive care, and even in the patients who have achieved a hematologic response, it's not all patients then go on to develop an organ response, and we can now replace organs that fail. So in order to facilitate earlier diagnosis, a main goal is to educate the community. As I said, the average number of doctors a patient goes to in order to, before they get a correct diagnosis, is 4. If the front lines or the community physicians or the nephrologists or cardiologists would recognize early symptoms, signs and symptoms of the disorder, then patients would be diagnosed earlier, which is important for in order to preserve organ function. We're also very excited about this initiative, the SAVE trial, which stands for Seeking Amyloidosis Very Early. This is a study that is being run through Tufts, where we're looking for specific plasma cell genes in patients with smoldering multiple myeloma or monoclonal gammopathy of undetermined significance. These are related plasma cell disorder, and there seems to be specific genes that put patients at risk for developing amyloidosis. In 18 patients that were initially screened, we identified 2 cases of undiagnosed amyloidosis. And if using this method, we can facilitate earlier diagnosis, that would be quite helpful for our patients. In the UK, they are looking at doxycycline, which is an antibiotic that may improve outcomes in amyloidosis treatment. Initially, doxycycline was used as prophylaxis in patients who are undergoing stem cell transplant as an alternative to penicillin due to mostly because of patient allergies, and it was noted that doxycycline, indeed, patients who received the doxycycline had a better outcome than patients who received penicillin. And this was prompted it to be studied in the non-transplant setting, and again, patients who received doxycycline had better outcomes than a control group. Doxycycline is thought to stabilize the light chains and prevent the misfolding. In terms of organ transplant, again, not everybody who achieves a hematologic response will improve their organs, especially if patients are diagnosed late and the organ dysfunction is advanced when at the get-go. Now, with the advent of directed donor and exchange programs where one's not on a list and competing with the general population, we have been able to get patients who ultimately developed end-stage renal disease, renal transplants in shorter order. At MSK, we have transplanted 16 patients. At BU, they've transplanted almost 50 patients. And again, you can see the median survival in both cohorts was excellent, over 15 years from their diagnosis. While kidneys are much more available, especially with this directed donor and exchange programs, unfortunately we can't do that with hearts, but there are available organs, and we have been fortunate to have 5 of our patients had cardiac transplants in the last 2 years. I am also following 2 other patients, one who was transplanted in 2008 and one in 2012, and both are excellent. And the last bit of information that needs to be known, now that we have second-line therapies that are effective, even patients who are on salvage therapy, after they receive a functioning organ, can do quite well. In summary, early recognition of the signs and symptoms of AL amyloidosis will result in early diagnosis, which is really essential. The goal of therapy is to eradicate the light chain producing plasma cell clone. Then organs can improve, but that takes time. That's why supportive measures are really essential. Autologous stem cell transplant with high-dose melphalan is still a standard, but gratefully not everybody is eligible, and so gratefully novel agents and approaches are finally being studied and appear promising. So with that, I'd like to close, and thank you for having me. Any questions can be directed to the ARC.